Nice introduction. Good afternoon, one and all, to all the members. I thank the chairpersons for the nice introduction, Dr. Roshan Kumar, one of my friends. I, along with my friend Dr. Chalapathi Rao, are going to present the most important yet volatile topic right from our undergraduate days. We try to make it simple as possible and hope it will be helpful for the postgraduate students. Okay, that is, the dentist needs a balanced view on occlusion, patient needs a balanced occlusion. Generally, all the dentists must have a clear understanding how teeth contact should occur both in static and dynamic positions in order to facilitate especially the masticatory function in a comfortable manner. Okay. In simple, rather dentists cannot repair or move or even remove teeth without being involved in occlusion. Hence, no escape for us. Yes, all of us here. The teeth masticatory system. Next. All of us repeatedly hear the O, that is TMJ. T stands for teeth, M stands for the muscles, and J stands for the joints. Today I will put it in different manner, that the stomatolic nervous system consists of masticatory system and articulatory system, as you are all visualizing. The contact of the teeth will occur as a result of temporomandibular joint and the muscle coordination constituting the articulatory system and the masticatory system, as for our users. Next time, there is the intersay. Articulatory system and the masticatory system are very much related and dependent on one each other. That is, TMJ leads to the articulatory masticatory muscles in the same way. They are all interdependent. Any change in the element in the system leads to the disturbance in the other elements which are harmful to the patient who requires rehabilitation. That is, even a small filling to full mouth rehabilitation. As a prosthodontist, it is our main objective for us to provide static and dynamic contacts of teeth, not causing disturbance to any element of the system. Now, the question arises, how do we achieve? So we call it as protective occlusion. That is, in other words, objective or ideal requirement of occlusal rehabilitation. In majority of the textbooks, we may come across around 15 to 20 points. Very difficult to remember rather. So for simple understanding, now I will put in the different manner. That is,
can't see the slides and
tooth level, at system level, at patient level. At tooth level, cusp to fossa contact, that is no incisal contacts. That is occlusal force directed down the long axis of the root. And at system level, that is centric occlusion, centric relation, freedom in centric relation, no posterior interferences. At patient level, within the adaptive capacities of the rest of the articular system, that is muscles and the temporomandibular joint. So for now, I stop here and I give the presentation. My co-presenter, Dr. Chalapathi Rao sir, will continue with the rest of the presentation. Dr. Chalapathi Rao sir, please.
Yeah, thank you, Sesha. Okay, right. Thank you one and all. Thank you, Dr. Roshan, Dr. Sima ma'am. And thank you all the organizing committee for giving me, and of course, my good friend Sesha to be a part of this. And of course, as I'm speaking about the protective perspectives of the occlusion, the rehabilitation, The first principle, probably I would put it as EDEC, where he is standing for an examination of the preoperative occlusion and even the entire system probably, and the design of the how you want to go ahead with the restorations. That may be in a provisional, right from starting from the provisional to the final, and then execute whatever you thought in the process. And then, of course, even after this, finally check the restorations of you had good. Then in this process of EDEC, probably firstly I would like to say, as an examination has been the first element of the understanding. So probably firstly you check with the TMJ, especially the sounds, tenderness, palpation, and how the TMJ has been the range of motions, as well as the muscles also, even of course the tenderness, etc., to undergo or to understand if any of the deformities with the structures of the masticatory system has been said as the muscles and joints will also be the part of it. And the next, coming to the teeth examination. So firstly, as a separate arches, if you see, there is a overload where you can see the wear facets or enamel fractures. Are there any abfractions where you can see? And even, of course, some of the mobility or anything which has been unexplained by periodontal disease, which you can relate it to occlusal disorders, where, of course, this is what is the most important concept where we are looking into. And then if you see most of the, as probably I say, intercuspal position is the first position, where you can call it as centric relation position also, centric occlusion. And some people say it is habitual, or some people, this is more of the controversial terms which you can, but of course, it's all the same, centric occlusion or maximal intercuspal position or the habitual centric positions where you identify the teeth contact, especially by holding any of the articulating paper, where you can see in a small discrete, or especially in young individuals, or a pinpoint contacts. Whenever you see the broad or anything, that means almost the teeth has undergone an attrition, right? But only thing is that's the observation of them. In the intercuspal position also, you will have to be observing for the horizontal and vertical overlap of the even anterior guidance or anterior teeth and how they influence the guidance of the mandibular movements. And then having known about the intercuspal position and the significance of the intercuspal position will be explained again to you in the approaches of the occlusal rehabilitation, where of course I can say which position has to be considered so that it is going to be protective to the masticatory as well as the articulatory system, which has been explained by my colleague Sesha Reddy. The next is the retruded contact position, where you call it as a centric relation position, where it is very difficult to identify or where it is difficult to locate, especially in the dentulous individuals, wherein of course in the edentulous individuals you can consider it as a bone-to-bone relation, but whereas in the dentulous individuals it is of course the tooth guided and the teeth guidance because of the proprioceptive, then they tend to go to the intercuspal position, but still you should you can of course guide the mandible by using any of the techniques what you are seeing. At the same time, identify the first contact in the retruded contact position. You instruct the patient to stop there, but if it is very difficult, then of course you can deprogram or you can do with occlusal stabilization appliances in order to arrive at a retruded contact position also. Otherwise also you can evaluate even of course mounting the cast in the centric relation or intercuspal position and then of course centric relation position and slowly do it onto the articulator. Then you observe for the first initial contact whether it is of course what it is best can be moved. Accordingly, in this position itself, where you have to understand as is there any slide between them, that is from the retruded contact position or centric relation position to the intercuspal position is to be understood. That is in terms of both qualitatively or qualitatively, where you will understand is that as a vertical and horizontal ratio, where you are seeing now vertical slide is being the more, where in the downslide it is the horizontal shift is being more. And at the same time, whether you have to restore to a retruded contact position or intercuspal position depends on the what kind of an approach you are using, or if the contact can be eliminated, which is also being a part of the treatment, then of course you can rely on to the intercuspal position, where of course you call it, understand it as a confirmatory approach, where you can see then of course the contacts are not being stable, where you will have to change the entire occlusal scheme of the individual, then probably I think you will have to go for a reorganized approach. This is all to protect the system only. Then again, along with the knowing the intercuspal position, the CR position, and the slide between the intercuspal position and the CR positions, you will have to be knowing about how the excursions occurs. Of course, where I had kept as a schematic diagram, where the first one is telling about the working and non-working contacts, and the non-working contacts should not occur. Where again you are seeing here the illustration as the canine guided, and of course this has been a mutually or group function, where it will be you will be using it to understand, or you will be using it to provide the occlusal scheme confirming to their guidances. Or you can even slightly change whether it can be a canine guided or mutually guided. And of course again you see the interferences, which are known to be understood as a deflective contacts, which are deflecting the entire movements of the mandible, wherein of course which are going to be difficult to cause the occlusal or rehabilitation. So lastly, another one is the loss of vertical dimension, where you have to go for an extensive procedures or extensive full mouth rehabilitation cases, where you all know the Tanner and Misserian classification. This is being illustrated through illustrated through this diagram, depending on the interocclusal space, where it is you call it as class 1, class 2, class 3, where you require, you all know probably, where you measure the rest position as well as the occlusal rest position, and also you need to include about the facial profile position regarding whether vertical dimension need to be regained or not, so that in order to prove or approve for the aesthetics of that individual also along with the function. So again, so having been known about all these basics, that is about examination of the individual arch, individual intercuspal position, centriculation, the slide, and then the guidance factors, and then the loss of the vertical dimension, whichever if at all been occurred, then you go into whether the restoration has to be done at a greater level or a different level. That is what you call it as to restore to good occlusal practice in order to understand this, or you restore to formal privilege, which has been habituated by that individual. So where, of course, we would put it as usually a confirmatory approach and then a reorganized approach. The confirmatory approach is nothing but you use the intercuspal position of that individual, where, of course, it is even if you can say it is almost a stable position of the jaws which are been existing, where you need not change anything, and patient is been already habituated towards that position. And then, of course, that's what is a confirmatory approach, where you can use it. So this is being, of course, one of the best advantage what you get is the minimal adaptation of the individual by which the individual can occur, and it can be solely confined to the only sum of the teeth whichever required. And index techniques also can be used so that it can be easy to fabricate. It is easy to do also. For the small number of restorations, of course, the laboratory procedures are also very simple. I will be explaining again what are the kinds of the posterior occlusal schemes what you have to go ahead with. Then the next one is when you see the muscle disorder or a TMJ joint disorder, or the positions where you feel there is a lot of slide between the intercuspal position to centriculation or retruded contacts position, as you have learnt already. Then if you want to have a stable position, and then when you want to reorganize everything, then this is what is called as a reorganized approach. So where you all are looking into provide the restorations into harmony with the new jaw relations. So that's the one where your crux is. So that's where the difficulty is existing. But still, when you have the complete knowledge how it has to go ahead, then probably the reorganized scheme also should not make any much difficulty as compared along with a confirmatory approach also. So primarily to understand basically what you want has been said by my colleague Sesha Reddy, what you exactly want in an ideal occlusion and a centric relation and centric occlusion coincidence, and the force to be direct long axis. And then of course there should not be any interference, there should not be any inclined concept, and of course you should have a harmonious contact with the system, that is probably with the muscles and the joints wherein, of course, in order to, where probably whether you want to go with a confirmatory approach or in a reorganized approach, but there are the posterior occlusal schemes which have been already been given in this textbook. Most of us know all these, but where it is, firstly it is cusp to fossa, where you can say a tripod contact, cusp to marginal or cusp to fossa is tooth-to-tooth contact, or the cusp to marginal teeth, again tooth-to-teeth contact, and the cusp to fossa, and where you can provide a slight amount of the freedom between the centric relation position and in a intercuspal position by changing the occlusal cable, what you're seeing right on the illustration, which is of course extreme light right diagram, then probably. So you should understand, only thing is you modify the occlusal surface in such a way they fit into it, and at the same time they provide the most comfort to the individual. All these things, all the schemes, whatever you are saying is been establishing, directing the force all along the long axis, all along the long axis forces, whichever is falling, are being well absorbed by the periodontal structures of the tooth which has been supported, as well as the other structures are also, and at the same time, that's how. So in the last case, what you are saying is that you are giving a freedom so that the patient can have some amount of the freedom of the movement between these two. Along with this posterior, whatever occlusal schemes you are seeing, then the probably along with this, you also have another factor which needs to be considered in developing the anterior guidance, where you call it as the overlap of the upper and lower teeth, which is of course should be resulting, providing the comfort, and of course it is resultant or it is going to be the anterior guidance, the posterior guidance also has to be in confluence with this. So that's how there are no deflections of the mandibular movements. Another biggest advantage or another biggest factor, what needs to be considered in the anterior guidance is, even if, of course, you are using the cement also, of course, even if you don't use the cement, but no cementation failure should occur. So understanding these posterior and the anterior controlling factors or all these occlusal schemes, why we need to do? It is also to protect the entire stomatognathic system, in turn that is masticatory system, as well as the articulatory system, and also to control the mechanical failures of the restorations also. Thereby, of course, the longevity of the restorations also will come. Along with the protection of the system, again the longevity, along with this additional benefit is the longevity of the cutting down the mechanical failure of the restorations also is another benefit what we get when we have a complete understanding of these occlusal rehabilitation procedures rather. So then, of course, I am going to share with some of you with probably the established concepts which have been already, philosophies which have been. Of course, this is the most oldest concept where you are understanding almost now. Of course, there is a retruded or RCR and ICP positions are being coincident, where you can use, of course, canine guided in the lateral excursions. That means the canine is the guide one, which is, of course, again, posterior disocclusion will be occurring. The anterior and posterior, again, are mutually protected, as you must know. Of course, when the anterior comes into contact, the posterior should go out of the contact, whereby anteriors are been protecting the posteriors. In the centriculation, when the posteriors are in contact, the anteriors are out of contact. So thereby, of course, the posterior teeth are been protecting the anterior teeth. In lateral excursions, whether it is canine guided or whether it is group function combined, that means canine along with the premolars on the side where you are moving the lateral movements, the other side, the gap is existing, thereby you call it as the mutually protective. So you please understand the crux of these, but of course the comments have been same, where you can use them. You should be using the adjustable articulator to do all these. And the area of the freedom, this has been already explained to you in the posterior occlusal scheme, that when you are not definite, or when you see the condition where, of course, slight amount of the slide can be occurred, or when you do the extensive restorations, of course, you can modify the occlusal morphology of the teeth, where the centric holding cusp meeting the fossa of the central fossa of the lower teeth within a freedom. So it's a small amount of the freedom. It's only just a modification of the occlusal surface in order to provide it. And again, you are seeing it is canine guided or group function you can apply. And again, anterior guidance also can be delayed or established with the posterior contact. And then again, useful for all these. Okay. And again, Pankman-Scheler, the most important concept which everybody applies, probably again, the area of freedom is occurring. Again, it's except that there is a difference where you create the morphology of the teeth by a functionally generated path technique. Again, if the anterior guidance is established at the temporaries, and again, canine guided or group function. Then again, Udelex and of course, Nyman Linde, probably I am telling you these two, I'll go a little fast because these are actually for an extensive advanced periodontal cases where you want to splint those restorations at the same time where of course it has to be undergoing the protection also where you can do by a splinting of the restorations. That means you splint the restorations together in order to cut down the share of the occlusal load between member of the occlusal loads. Okay, so that's how you can understand in simple way. Probably even Nyman Linde is same almost. And then most recently, all the people are either follow Pankman-Scheler or Hobotin stage, where of course I have not kept you in detail because you will not understand when I probably in the next convention, if any opportunity comes by the Bali, I'll present it as in terms of the case reports of the Pankman-Scheler as well as the Hobotin stage to understand them. But right now you should just understand the basics, that is anterior guidance and the condylar path are being interdependent, which are dependent on again angle of hinge rotation and the cusp angle factors. So that's how there are controlling factors which you call it as disocclusion, and without disocclusion where we establish the first one, the without disocclusion, and then of course the anterior morphology and anterior guidance also is being provided within a standard amount of the disocclusion. And this is what is the most important things which you understand as in a philosophical philosophies of the occlusal rehabilitation, all been directed towards the observation of the natural systems, and then they adapted. You can choose any of the system for your needs probably. So if you're understanding the basics of the positions of the teeth as well as then of course which technique you will have to be identifying which is comfortable to them. Then with this probably I have completed the philosophies which has been there in the literature probably. Now I am trying to go ahead within a sequential preparation so that probably all the postgraduate students and I can understand how to go ahead with a full mouth rehabilitation cases you come across in the clinical years. But it is very unfortunate, probably all the final year postgraduate students are exam appearing, they are not been attending, most of them, or if they are attending, probably I think it's a refreshing knowledge to them. And I know almost last 1 year we have been in the COVID season and most of the second years who are entering the third years also probably not have come across this, but this can act as only a tips to do the full mouth whenever you come across in a full mouth rehabilitation cases. And with all this understanding, probably I would say occlusion should not be reorganized unless there is a good reason to do so. Because don't simply to jump on to the reorganized approach will make a lot of problems in the entire masticative system. Wherein, of course, where I'll tell you as in a sequential process of the going ahead with an occlusal rehabilitation, so that which is protective in nature in terms of the teeth which are holding the restorations, as well as the restorations which are the contact between the restorations is also being compatible with the muscles and the joints which have been existing, which is, you can call it as probably an entire intricacy of the maintaining the intricacy of the entire stomatognathing system. So where it is, of course, I had put it as in a sequential process, probably for a simple understanding. Okay, the first step is being tried to avoid. I do not say that don't go to reorganize, but unless until you have a complete knowledge of the understanding of the basics, then you can, of course, always go for a reorganized. But please don't misunderstand, try to avoid the reorganized approach. Okay, because it's a very difficult process. The consequences of failure are more as if you don't understand and if you do not apply it properly. And even if large cases if you have, okay, as long as you see that there is a strong intercuspal position where the patient can rely upon, where of course he can be comfortably provided with an occlusion in the intercuspal position where he has been already habitually directed. So then of course you can have an index technique, and then of course you can conform to these techniques. This only thing is you can split into the stages and you can go ahead also. Okay. Then that's how probably to find the centriculation, first one is, so where you, of course, especially this is most, I'm not trying to explain about the confirmatory approach as it has been simple in understanding, because where you are using the existing intercuspal position itself to use it. But when you want to reorganize, then of course it is your first primer is to know about the centriculation. The initial contact, what you are seeing in the second illustration, has to be identified. If it is a part of the treatment which can be removed, and of course patient goes to the intercuspal position comfortably, then of course you can come back to intercuspal position where instead of going for an instead of going for an reorganized approach. This is how, or if you have any difficulty with this, of course, where our last illustration is also through an anterior stabilizing appliances, along with the deprogrammers to arrive at the particular situations, right? And then there is an equilibration. This is how, probably, as I told you, if you have a problem, then of course you can have a mounted diagnostic cast, then you can move the jaw to the various positions where you can, of course, do the equilibration of the accurately mounted cast. You can mark on them, and provided the interference are been occurring, then of course you all know MUDL, LUBL, and where the first letter M stands for mesial, U is for upper, D is for distal, and L is for lingual. That means you are correcting the interference is between the mesial and upper, and the distal and lower, and upper buccal, lower lingual, upper lingual, and then buccal lingual. So this is how the process of the alone standing teeth or interferences can be reduced and can be removed so that you have a stabilized occlusion. Along with this mounted diagnostic cast also, whenever you are going for an extensive rehabilitation process with a Broderick Phillips flag analyzer, then you go ahead with an occlusal planalyzer so that you will have going to produce an even contact of the teeth in a plane which is going to be in accordance with the joints as well as the muscular function, right? Then the next one is, of course, you can do on the mounted diagnostic cast also, you can prepare, then you can do the diagnostic wax up so that how you want to do. And of course, you can go for an either cusp to fossa or cusp to marginal ridge or cusp fossa within a freedom of the centric. Either of them, I put it as simple as the form allows the function or follows the function. That means the morphology what you are creating to the posterior teeth are going to be deliberately allowing you to function in a normal manner. So it is also, that means it's also like contributing. Of course, you will see that there is now food impaction also between the embrasures of the teeth. So that means that's how you should be developing the context. That's how you will be developing the occlusal, entire occlusal surface of them. So that's how I can put it as in a simple way, this is how. Whether you rely upon any of the thing, there is no problem. And again, the same posterior guidance or the posterior contact of the teeth also should occur along with an anterior guidance what you establish. That can be through, of course, whatever your illustration. It can be a customized guide table what you can enhance. And there is also a Customer Go guide which you can help it. Of course, once it is the anterior guidance has been established, you can drop in a liquefied wax into it, and then you can put it onto the occlusal surface to carve all the occlusal modifications. That is how the cusps, marginal ridges, etc. So that again the patient can be doing a amicable function. And then firstly, then after all these evaluations, then probably you go ahead with the preparation of the teeth, and then you construct the provisional restorations. And these provisional restorations also can be re-verified again on the articulator in all the various sections. And then again, the same provisional restorations again can be rechecked in the oral cavity, right? On the oral cavity, of course, on the mounted cast as well as then onto the patient's mouth. Then once you feel that the established contacts are entirely proper, then you cement the provisional restorations, then you make an impression so that it acts as an again guide once again to establish all the contacts in the definitive restorations. And then go ahead with the fabrication of the definitive restorations, provided either you can do the posterior restorations or first you establish the anterior guidance or you establish on the anterior restorations. Then of course, along with them, then of course, in order to be confluence with the anterior guidance, then again, you can fabricate to go ahead with the posterior restoration. Either of them, but you should be maintaining the stability of the restorations in all these positions in order to understand, in order to probably to deliver the forces or in order to protect the entire stomatognathous system. Then in this process also, as I've been already told you, the crux of the probably protective understanding, so where it is to direction of the forces all along the long axis, again, protecting the integrity of the system. Supposing if you are finding any of the parafunctional habits, after doing the, or if you are going on with the full mouth rehabilitation habits also, but habits die last, okay, they never die. So that's how probably what you can do is you can protect all these restorations also by providing an overlay splint with a thermoplastic sheet, whatever you can split, if at all required. Okay, so this is how the process of the full mouth rehabilitation in a simple manner, right? So then, of course, lastly, I would like to say as a no dental service can be of value unless the entire mouth is studied and treated as an integral unit. Probably with this, I tried to make as much as short as possible, and I tried to make it as concise as possible. It is for a simple student to understand how an occlusal rehabilitation as such. But of course, in terms of the probably as in a theoretical background, I didn't want to explain much because all of you are very primitive at the stage of this full mouth rehabilitation. Probably I'm expecting much of the second year students here. Lastly, I would like to thank my mentor. These are my references probably. And my mentor and organizing chairman also.